Introduction to Psychiatric Nursing Part 2, Behavior Therapy, Milieu, Therapeutic Relationships, and Group Therapy. The reading for this lecture is Erstmeyer, Chapters 1 and 2, Halter, Chapter 2, Yalom, the prologue from page 3 to 14, and Chapter 5 from Yalom, I Never Thought It Would Happen to Me. Also, the fourth thing is a short article by Dr. Ken Stanton on an introduction to psychiatric nursing. So our last theory that we'll talk about is behavior therapy. Just some basic concepts. These are probably familiar from your prerequisite psychology course. Classical conditioning. This is the famous where a stimulus is paired with a reward. You might remember Pavlov's dog, where they did an experiment where the dog, when they got fed, they would do a bell, and then after a while, the dog would salivate just to the sound of the bell with no food present. So that's classical conditioning. It's passive. Then we have operant conditioning, where you have to actually operate on the environment. This is made famous by B.F. Skinner, and it was where I think he used lab rats. They had to push on a lever to get their reward. So they had to actually do something to get their reward. And then we have exposure therapy. We use this with patients that have phobias a lot. And this is where, and the phobia, just to be clear, it's something that really isn't dangerous. And so the person is exposed to it, just kind of constantly until their system realizes it's not dangerous. And so that's exposure therapy, also called flooding, or also called implosion therapy with an I. Another concept we have from behavior therapy is a token economy. We use this on adolescent units and child units, where a patient, when they're doing the behaviors that we want, going to groups, cleaning their room, those kind of things, they earn points, and then they can exchange those points for stickers and art supplies and things from the unit, where we have little cheap things that they can buy. It's a way of giving positive rewards for the behavior that we want. So some of the uses these days that are very useful are habit control methods. There's a Stanford professor, B.J. Fogg. He wrote a book about 12 years ago, 12, 13 years ago, and he made it for the general public. It was titled Tiny Habits, and it describes the current behavioral approaches to habit control. He maintains that all behavior, whether it's something you want to change or not, occurs as a result of just three things in their interaction. The first one is motivation. The higher your motivation, the more likely you're going to perform the behavior. Number two is the ability. The easier a behavior is to perform, the more likely the behavior will occur. And then three, the prompt, also known as triggers or cues. So all behavior that occurs has some kind of prompt. And so, those are some other, that's another area where, if you have a bad behavior you're trying to stop, you can try to remove the prompt. So this is a graph that just kind of shows the model. And you see the green action line, things that occur where they're on the right side, the right upper side of the action line. That's where the behavior is going to actually occur. And then below that line is where the prompts fail, where the behavior does not occur. And so with high motivation, you can see if something that's hard to do, very hard to do, if the person has very high motivation, it can still happen. But one of the things to know about motivation, which we'll talk about in the next slide, is it's very hard to maintain. That's why a lot of people that have, a New Year's resolution, it fails within a couple of days, because your motivation, it's waxes and wanes. It doesn't stay consistent. So, what one thing BJ Fogg recommends is that when you're trying to start a new habit or stop a bad habit that you don't want anymore, um, you have to, if you're wanting to start a habit, you make it as easy to do to start as possible. You break it down into the smallest, easiest step, and that's so that you don't have to have that really high motivation to have the behavior occur. Um, yeah, so he tries to, over time, you build up to that, and then if you have a habit you're trying to stop, you do whatever you can to remove a prompt. An example of removing a prompt is, I'll give you an example. I realized I was getting a little lazy with my diet, and I would order Grubhub too much, and so I removed the app from my phone. I can still order it. I can still, like, it only takes a minute to download the app, but it just makes it where it's not as easy to do. And so you remove that, try to make it as difficult as possible for a behavior that you're trying to reduce or eliminate. All right, so like I said in the previous slide, motivation is very hard to sustain. Um, a lot of times we blame ourselves for that when actually it's, a lot of the approaches to changing habits, it relies on you having a lot of motivation. And really, that's where the fault is. So you shouldn't be blaming yourself. You should be blaming those approaches that make you rely on maintaining an unrealistically high amount of motivation. So what you want to do is make a small change and have that build over time. So for, like I said, for a habit to stop, the inverse is true. You want to make it hard to perform. You want to remove the prompt. Um, And these concepts, they've been very useful for weight loss, stopping smoking, starting steady habits, and other issues as well. Milieu therapy, also known as the therapeutic community, this is where, in the hospital, everything that is around the patient, we want it to be as therapeutic as possible. And so not just the time when you're meeting with the doctor, not just the time when you're in a group therapy, but also just kind of hanging around with the other patients, watching TV or whatever. We want it to just the setting to be therapeutic. So a lot of what they have to do, though, an example, they have to, they're usually watching TV, so they have to decide what to watch. They have to manage, when there's disagreements. Um, those types of issues are considered therapeutic and part of the milieu. So basic assumptions, the health of each individual, we're trying to have everyone grow. Now, part of an inpatient hospitalization is we're generally trying to get them back to their previous level of functioning. We're not really trying to get them up to Maslow's highest level that you learned in the earlier half of this lecture. But we do want them to grow. We do want to encourage them. And so every interaction, positive or negative, is an opportunity for insight into that. Patients are responsible for their own behavior, um, and we try to look beyond just the surface. That we, when there's behavior that needs to be redirected, we want to make sure we're just focused on the behavior, not that they're a bad person or anything like that. Um, and then sometimes you'll have a lot of unstable patients, but they'll do okay because there's peer pressure. They don't want to upset the other patients. And then, like I said, the inappropriate behaviors, we deal with them as they occur, and we try to be as forgiving as we can as far as things like consequences. We just want it to be natural, and we want to facilitate their insight into things as much as possible. So conditions that promote a therapeutic community. So basic physiological needs. What we mean by that, a lot of our patients, they haven't been getting their meds consistently. They haven't been getting sleep. They haven't, they've been living these very unstructured life sometimes. They're not getting meals on time and they're not getting nutritious meals. And so we try to have that kind of structure in place where those basic needs are met. And then we have social activities. A lot of our groups are social as well as being therapeutic. There'll be art therapy. There'll be, you know, sometimes movies that are part of the treatment. And, you know, on the adolescent unit, they'll have physical education. So the program, the care, there's an interdisciplinary team, and treatment planning generally happens 2 to 3 times a week. It's usually on the day shift. So if our rotation is in the evening time, we don't really get to see that. But what I've found in the past when I had day shift rotations is that there's a lot of lingo that you're not familiar with that you have a hard time following anyway. So you're not really missing anything. But all of the disciplines come together and try to make as personalized a treatment plan as we can for the patient, and with a real focus on getting them to a place where when we discharge them, that they don't come right back, that things are addressed that need to be addressed. So there's always a nurse 24 hours a day. If you work on in acute nursing with inpatients, one of the downsides is you will probably work every other weekend. That's kind of the standard. You'll, there's evening shift, there's day shift, there's also night shift. Sometimes when you're first starting out in your career, you'll have to take a job on a shift that you really don't want, like a night shift job. But we have to be there 24 hours a day. So we have to make sure all of their needs are met. Therapeutic relationships. So a therapeutic relationship, it's different than your other relationships because even though it might help you to help them, the focus is on helping them. The goal is to help them with their issues. Establishing the foundation of the therapeutic relationship is our first priority. When you come out of report, we go and we check on our patients, and it's not just to make sure they're safe and everything like I may have talked about before, but we also want to have a connection with them. One of the issues in psychiatry is patients get anxious when it's shift change. They have to kind of let go of their previous nurse, and they don't know what the next nurse is going to be like. And so we want to go kind of put them at ease, and also do our brief initial assessment and make sure they're doing okay. When we talk about therapeutic use of the self, we're really just talking about our interpersonal skills that we've had for most of our life since we were a baby, our ability to connect with people, and whatever else you have skill wise, your ability to make eye contact, to convey that you're an empathetic person that's going to be helpful to them. Those communication techniques that you might not feel like you have, but you do, because you've been on this earth for quite a while. You learn how to use those in your relationship with the patient. So these occur when, we have to see the patient as a human being. One of the problems that I see sometimes is nurses will hear report on a patient, you hear about their diagnosis and their issues and maybe some outrageous things that happened in the crisis that brought them into the hospital, and you don't really see them as a real person. And so that's one of the places we want to start. We want to connect with them as a person. And then, it's of course a two-way street. We don't control their side, but we do the best we can. Um, they have to kind of connect with us that same way, and then that can be a really therapeutic relationship. But still, even if they're not at that kind of place where they can connect with us, we still do our best to connect with them. And like I said, the relationship is goal oriented. We're trying to help them with whatever they need. When we talk about the use of ourself, we're talking about our skills in the interpersonal area. Um, you have to have some awareness of yourself, of what your beliefs are. Sometimes patients are in a crisis, and they are searching, and our job is to not search with them. We need to kind of know who we are and what our beliefs are and our feelings about things, and not try to impose them on the patient. We want to help them explore theirs, but it's also important that we kind of have a grounding in ourselves. And it's one of the reasons why I have you guys read the Irvin Yalom book, the kind of existentialism, and see how he manages that. Transference and countertransference. So transference, let me just let me back up a second. So all of our relationships, we go in with a certain expectation based on our experiences with people that this person might remind us of. We call this transference when the patient has a feeling about you that has nothing to do with you. Um, Usually this is something that happens all the time in every new relationship. And where it can go wrong in on a psychiatric unit, for example, you might, through nothing that you've done, no fault of your own, you might remind them of someone that has mistreated them in their past, and they might treat you in a negative way. And then countertransference is the opposite. We as nurses, we're also human beings, and we might have had a patient that this patient reminds them of that they had a negative experience with, that maybe was abusive, or something of that nature. It can be that the person reminds you of somebody from your personal life, maybe your parent or something like that. Um, and so our responsibility is just to be aware of our own feelings, and try to make sure you're not mistreating the patient because of feelings that you've had. Now, the transference can be a positive thing too. Sometimes the patient, you're a nurse, and so they, most of the time, they do have an expectation that you're going to care for them, that you're going to be empathetic, and these can be positive as well. Like I said, these are in every relationship. In looking at my relationship with you as my student, you came into this relationship with an expectation based on your previous, might be your previous nursing professors, might be your previous psychology professor. It might be, I might remind you of somebody else from your life, your feelings in general toward authority figures. Maybe authority figures have been good to you, and so it's a positive transference. Maybe authority figures have been, not good to you, and you have a negative transference. The more you get to know me, the more your feelings about me will be about actually me, and not your history of someone that I might remind you of. And the same is true, for me with students. And so those are, just be aware. This is something that's present in every interaction, every relationship that you have. One thing in the psychodynamic psychoanalytic theory, that's the reason why the therapist sits behind the client the client will be laying on the couch talking. The therapist sits behind them and doesn't say very much. And that's because they're trying to encourage the transference. And so, they use that as a therapeutic technique. They use that dynamic that naturally occurs and they try to exploit it, make it stronger, because they believe that if the client transfers their feelings toward the person that may have been a significant person in their past, like a parent, then you can work on those feelings more. So conditions essential to the development of a therapeutic relationship is, first of all, rapport, that connection that we want to have with a patient. Trust. You want to communicate the best you can, that they can trust you in whatever way you do that. Respect, genuineness, that you're not trying to act like you're feeling a way that you're not. And then empathy, that you're not having sympathy for them so much, because that's not helpful, but you're able to understand what they're going through, and you feel for them. Phases of the therapeutic nurse-client relationship. The first phase is before we even meet the patient, where we're hearing a report. We call that the pre-interaction phase. And we're getting the S bar from the previous shift. And like I said earlier, one of the things different is you hear a report on all of the patients on the unit. That's one thing different than a med-surg unit, because all of the patients could be your problem. And so you have to be aware of what's going on with everyone. Anyway, so this is where you haven't met the patient yet. And if there's things in the report that are upsetting to you, you need to deal with them before you meet with the patient. And what you'll want to do in real life and on the NCLEX is talk to an experienced nurse about your feelings before you act out those feelings with the patient. The orientation introductory phase. This is where you're going around and you're introducing yourself to your patient, and you want to you want to try to create an environment where there's trust, there's rapport, an idea of what we want to get done this shift. It's usually your 8-hour shift, and what are the challenges? What are some things that we can do? What are some strengths? Um, what are what's their goal? What's some limitations? How can I help you? Like, if you feel like you're going to get upset when your visitors come, I can try to give you some medication before then, um, or we can talk. Just do a brief one-to-one. Do some deep breathing exercises, those type of things. Formulate some ideas. Nursing diagnosis, we don't really use that much, but what we really mean is just what kind of problems we're going to work on. Have some goals, a realistic plan of action. Sometimes patients, you have to redirect them from having too big of a goal, and make sure it's something they can be successful with. And then your feelings about it, their feelings and your feelings about what could go wrong, what do you think is going to go right. Then the working phase is where you're actually doing the you know doing the plan that you came up with. And so you're trying to do it. If you're having to do redirection, you want to be able to maintain your trust and rapport with the patient, help promote their insights, um, work toward those goals, overcome resistance. Sometimes they want to achieve their goal, but there's things that are blocking it, and evaluate their progress. And the termination phase, especially if when you're new as a nurse on the unit, you're going to be floating to different units. So you don't always know if you're going to actually ever see that patient again. Our stays are usually pretty short, both in psych and in med surg, and in other settings as well, I believe. Um, so you want to talk about what you accomplished, what still needs to be done, anything that they need to talk about to process before the end of your time with the patient. All right, boundaries in the nurse-patient relationship. Boundaries are important in all of our relationships, but especially in our relationships with patients. Some of the concerns commonly that come up, self-disclosure. Um, I'll give an example for myself. I'll tell patients basic things about me just so they feel like they know me. I'll tell them, I'm married, I have cats, I have, those type of things. I'll tell them I've worked at the hospital for a long time, and um, but I won't tell them any of my own problems. I won't tell them things that are really personal. Um, some of the things that you'll want to know about self-disclosure. You might have a patient that's on a medication that you tried at one point in your life, and that would be inappropriate and could even get you disciplined. Um, so we don't give advice. We don't tell patients about our own personal problems. You don't tell them about when you went through a bad breakup or when your parent died or whatever kind of things that challenges you've had in your life. Um, and so we can kind of keep that tight. But like I said, once you have experience and you know what you're comfortable with and you know what works to make patients comfortable with you, then you do that kind of self-disclosure. Gift giving. Sometimes patients will want to give you some kind of little gift, usually a little something that they made in the art therapy. I had a student one time where the patient gave her this drawing, and then when you looked at it really close, it said, "I love you." So that was inappropriate. We needed to talk to him about that. Um, and then there's sometimes staff will want to bring in something special for a patient, and that's inappropriate also because all of the other patients, will see that you're playing favorites with that one patient. Touch, we have to be very careful with touch on a psychiatric unit. Um, it's always a good idea in any kind of nursing to ask permission before you touch someone, especially if you're doing a bed bath or doing something really where you're needing to touch them in more personal areas, like even doing an EKG, especially when I'm a male and I'm doing it on a female. And I always have a female nurse or mental health worker in the room. But always make sure they know what you're doing and why you're touching them the way you're touching them. And there's something we call trauma-informed care, where we try to treat all of our patients as if they've been traumatized. And the fact is, most people have in some way or another. So especially around touch, people have been touched when they didn't want to be touched in inappropriate ways, and you don't want to remind them of that. And so the last one here, friendship or romantic association, that's a good way to lose your license and get kicked out of nursing school. And I know people think, you think you're never going to fall in love with a psychiatric patient, right? Um, but you don't understand. Sometimes these people are very appealing. They're human beings just like us. They might be very high achieving people, very intelligent, especially with some diagnosis. Um, People with things like bipolar disorder can be very high achievers, very smart, very charismatic, and people that you might have a relationship with if you didn't meet them in the hospital. And so you always have to keep your boundaries up. Um, and you can't really be friends with them either. Sometimes patients, when they're after they're discharged, they'll want to call the unit and ask for you and just kind of tell you how they're doing. And you always want to keep those conversations, friendly but brief. You don't want them to, you're not going to be part of their support system once they leave the hospital. You don't want them to see you that way. And you also can't be friends. You're not going to be hanging out with your former patients. All right, warning signs that that your boundaries are in jeopardy. And so realizing that you're prioritizing the patient's care over another patient's care, keeping secrets with a patient. They tell you, patient tells you something like, look, there's something I want to tell you, but you have to keep it between us. And you can't promise that to a patient. You don't know what they're going to tell you. They might, you're a mandated reporter. They might tell you something that you have to report. And also, it's not therapeutic. You need to, they need to see you as representing the care team, and anything they tell you should be something that you can put in their chart because it could end up being significant. Um, Changing the way you dress for working with a particular patient. You know that on Monday and Wednesday you don't usually float, but on Tuesday you do. So on Monday and Wednesday you wear your figs, your fancy nurse scrubs, and then on Tuesday you wear your cheap scrubs, your Cherokees. And so just being aware of that, um, that you're doing that, and that means your boundaries are starting to get kind of slippery. So another is your charge nurse assigned you to other patient, and then you try to get the nurse that has a patient that you like to trade with you, giving special treatment to one patient over another, and then spending free time with the patient. I had a nurse one time when I was evening charge nurse. He floated down to my unit from another unit, and he spent a lot of time with this girl that was going through, her parents were going through a divorce, and she was having a hard time with it. He did a long one-to-one with her, like 30 minutes, maybe longer. And then the next night, he was back on his home unit. At his dinner time, he came down and talked to her some more. And so, you know, you can't spend your free time with a patient when that's not your patient anymore. That patient has a nurse on this shift. And so I had to talk to him about boundaries about that. And he was fine with it. He was a nice guy. I think he left nursing to become a therapist. So I hope he has better boundaries as a therapist. Okay, other warning signs: sharing personal information, work concerns, um, confiding in the patient. That's inappropriate. Thinking about the patient when you're away from work. Now, sometimes you can't help it if there's a patient. For me, it tends to be a patient that got under my skin, that bothered me, and it'll make me mad if I find out I realize I'm thinking about them when I'm not at work. Um, having a dream about a patient, and like I said, it's usually it's usually a patient that was annoying, that bothered me, that makes me think about them away from work. But thinking about them, thinking about how they would see a situation that you're going through, um, yeah, those are the danger signs. And then receiving gifts or having any kind of continued contact after discharge. We had a therapist that when kids were discharged, he would let them friend him on Facebook, and so he almost got fired over that, even though he didn't do anything inappropriate. But still, that's inappropriate in itself, letting patients friend you on Facebook. But there was he didn't go out to coffee with them or anything, at least as far as we know. Group therapy. So that's our primary mode of therapy on the unit. They do have a you know, half an hour or so that they talk to their psychiatrist during the day, sometimes longer, sometimes shorter, depending on what they can tolerate. Um, we have different types of groups on the unit. We have groups that are based on a task where there's art therapy. An example is, we just had the holidays, so, Christmas type of decorations and maybe attached to a pleasant memory from a holiday. Teaching groups where there might be a certain focus, maybe discharge planning. And we have our supportive slash therapeutic groups, also known as like a process group. And that's where we have patients talk about the issues that brought them in, the primary stresses that they're going through, the different types of ways they can be reacting, and having other patients do the best they can to be supportive. Physical conditions that influence group dynamics. So seating, so if you want to, I know on my slide here it says it's best when there's no barrier between them. Let me rephrase that. It's more intimate when there's no barrier between them. So, for example, with a group of high functioning patients that can tolerate that kind of intimacy, it's good to have no barrier. That's why you'll see the seats in a circle with nothing in between. Um, then, on the other hand, when there's chairs around a table, that's good for patients that, there might be patients that are paranoid or really can't tolerate that kind of person right in front of them. And so yeah, that's a consideration. And then when we do have the chairs in a circle like that, we don't want to have someone blocking the way out. We want to have an opening where an agitated person, if they want to leave the group, they don't have to walk around somebody, because there's always the chance that they're going to hit somebody when they're leaving if somebody's in the way. And then the ideal size of a group is about 7 or 8, but we really can't control that on a unit sometimes. Um, if there's patients that are appropriate, we'll try to make it where, sometimes you can have like 12, 13, 14 patients in a group. But we try to not have patients there that can't tolerate it or that will be disruptive. And so, and that's one of the things you can't really control on an inpatient unit. Sometimes outpatient units, you can control that kind of thing. Yalom's 11 curative factors of group. So what we're talking about here is what is it about group therapy that's helpful? And so, he has these 11 things that he believes are the things that in groups are helpful. So installation of hope, seeing others with similar problems to you get better, it gives you a sense of hope. Universality, this is where you see other people that have your same problems, and even though it might not help you, you might not be seeing things. It still feels better to not be the only one with your problem. A lot of patients come from situations where they're living with their family, and they're always the sick one. They're the sick one, the identified patient. But they, it feels better when there's an old saying called misery loves company. When you see other people that have your problems and struggling with them, it just feels better to not be so alone. And then imparting of information, even patients learn a lot from each other just because they're dealing with the same processes, the same mental health system, sometimes dealing with the same pharmacies and psychiatrists, and so that's useful as well. Altruism. Altruism is when you feel better just by helping other people, and so that makes you feel better about yourself. A lot of us are nurses because partially because it feels good to help people. And then we have the corrective recapitulation of the primary family group. So sometimes you can have family conflicts that are unresolved, but you might be able to work through them in a group where you can actually understand why your family members are acting a certain way. Just it's always easier with strangers for some reason, because there's not such an intense connection like it is with your own family. And we have the development of socializing techniques just by you know, getting feedback, finding what behaviors that you do that upset people and what behaviors that you can do that people like. Imitative behavior, where you kind of see people doing better on the kind of things that you need to do, and you just kind of act like them. And then interpersonal learning, where you interact with people and just kind of learn just through the interaction. Group cohesiveness, where you always feel it always feels better to be part of a group than to be on your own. Um, you'll notice that when you get out of nursing school, in nursing school, you might not realize it right now, but you're part of a group, and you all have the same goals. You have very similar experiences. You have similar stresses, and it feels good to be part of a group. When you get out of nursing school, it'll be exciting because you're going to be getting jobs and making money and all of that good stuff, but you're going to miss the fact that you're part of this group. You'll be a part of another group, hopefully soon. You'll be part of coworkers in a hospital. Um, but you'll find that, people are in different places there psychologically. It's not the same as when you're in nursing school. And there's catharsis where you can express your negative feelings kind of intensely in both positive and negative ways. And then Yalom, remember Yalom is the person that he's one of our primary theorists in existential theory as well. So he sees that as people having a chance to take responsibility for their own existence. This is where I feel like he kind of imposes his theoretical perspective from just his individual therapy onto the groups. But I can see that. I've kind of seen that as well. All right, a question. Um, After a supportive therapeutic group, a nurse hears one client say to another, quote, "I never thought that other people had the same problems that I have." The nurse ascertains that this statement represents which curative factors described by Yalom. A, catharsis. B, group cohesiveness. C, universality. D, imitative behavior. If you want to take a minute to think about this, go ahead and stop the video because I'm going to give the answer in just a few seconds here. Okay, the answer is C, universality. Right, this has been Introduction to Psychiatric Nursing Part 2. We will go over in a live lecture when we review this pre-recorded video. We'll go over the study guide and all of the objectives.